And today, we are tackling a field that, it touches millions of lives. It really represents one of the most profound scientific evolutions in pharmacology. The drugs used to manage mood and anxiety. Our foundation is a specialized textbook chapter on psychotropic agents, and the landscape is, well, it's vast.
So we're not just reading definitions today. Our goal is to give you, the learner, a clear, structured understanding of how these drugs actually operate, why the newer ones replace the older ones, which is fundamentally a story about safety and how treatment strategies are, custom tailored today.
We begin in the challenging realm of what are called affective disorders, and these are essentially pathological changes in mood. We'll be focusing primarily on major depression, which is characterized by that profound sadness and hedonia, low energy, and sometimes suicidal thoughts. And of course, the opposite extreme of that.
Mania.
Mania, exactly.
It's just so vital to remember the scale of this problem. The sources really emphasize that anxiety and depression are described globally as the leading psychiatric disorders. These aren't fringe conditions at all.
Not at all. They represent massive public health challenges, which is why the development of effective and crucially safe treatments has been an urgent priority for decades now.
Right.
And the overarching principle, the one thing we have to establish right now, is that an antidepressant is defined by its ability to elevate mood in depressive illness. And practically all of them, regardless of their specific class, they ultimately exert their effect by affecting the communication of monoamines.
These are chemicals like noradrenaline and serotonin.
That's right.
In the brain. So we're going to trace the history of this chemical manipulation. We'll start with those accidental discoveries and, frankly, the high risks of the first generation, then move through the safety revolution and land on the specialized tools we use today.
Which means we'll be covering the MAOIs, the TCAs, the celebrated SSRIs and SNRIs, the so-called atypicals, and then finally the specialized anti-anxiety agents like benzodiazepines.
Okay, so to really grasp why these drugs work, we have to start with the foundational theories of depression itself. For the longest time, the reigning theory was, it was elegantly simple, wasn't it? The monoaminergic hypothesis of depression.
It was. This hypothesis was basically built on reverse engineering the effect of the early drugs. The core observation was that if a drug made someone less depressed, it invariably increased the availability of noradrenaline and/or serotonin 5-HT in the brain.
Right. So the logic follows.
So the hypothesis proposed that depression itself must be caused by a deficiency of these monoamine transmitters in key areas like the cortex and the limbic system, which, regulate our emotions.
It's a very satisfying cause and effect theory. If the illness is a deficiency, the treatment is simply replenishment.
Exactly. And we saw this evidence so clearly as every class of effective antidepressants, TCAs, SNRIs, SSRIs, the atypicals, they all seem to converge on increasing that NA and 5-HT availability.
They just do it in different ways.
Precisely. They either do it by inhibiting the reuptake transporters, which is just the cell's way of recycling the neurotransmitter, or by stopping the metabolic enzymes that break them down. Either way, more NA and 5-HT are left hanging around in the synaptic cleft to communicate with the next neuron.
But as you alluded to earlier, the simplicity of that monoaminergic hypothesis, it kind of broke down when we started observing the timing of the treatment.
Yes. This is where the intellectual pivot really happened. If you take an SSRI, let's say fluoxetine, the drug is absorbed, it enters the brain, and it blocks the SERT, the serotonin transporter, within hours.
It's working immediately.
Mechanically, yes. Yet the patient reports no significant mood change for 2, sometimes 3 weeks. And if depression were merely a chemical imbalance, the relief should be, it should be immediate. That lag time was the giant hole in the hypothesis.
And that delay led to the aha moment that really redefined the entire field.
Yeah.
The neurotrophic hypothesis.
This moves the definition of depression from a purely chemical problem to a structural or a functional one. The neurotrophic hypothesis suggests that depression isn't just a lack of neurotransmitter, but that it's associated with a deficiency of nerve growth factors, particularly brain-derived neurotrophic factor, or BDNF.
And we know BDNF is crucial for what?
We know it promotes neuronal survival and plasticity. It helps neurons grow and form new connections.
And there's physical evidence to back this up. The source material points out that a reduction of BDNF levels has been observed specifically in the hippocampus, a critical region for mood, memory, emotion of depressed patients.
Which suggests that depression might literally involve a physical wasting or a retraction of healthy synaptic connections.
Wow, so it's a huge shift.
It's a massive shift. You can think of the brain as a garden. The monoamine hypothesis said the garden is dry, so add water, the neurotransmitters. The neurotrophic hypothesis says, no, the garden is failing because the soil lacks fertilizer, the BDNF, and that's causing the plants to wilt, which are the synaptic connections.
So the immediate action of the drug-blocking reuptake, that's just the starting gun. It's not the finishing line. The question then becomes, what is happening during those 2 or 3 weeks when the mood gradually starts to lift?
And that's the mechanism of time-dependent change. The initial increase in monoamines, that's just the trigger. What happens is the sustained increase in NA and 5-HT is sensed by the neurons, and critically, it triggers a process known as presynaptic autoreceptor desensitization.
Okay, you have to explain that for us. What are autoreceptors and why is desensitizing them so crucial?
Autoreceptors, like the alpha-2 receptors on noradrenergic neurons or the 5-HT1A receptors on serotonergic neurons, they function as the neuron's internal thermostat. Or maybe a better analogy is a brake. When the neuron releases NA or 5-HT, the autoreceptors sense that concentration is high and they signal back to the cell body to reduce further release.
They're the brakes on the system.
They are absolutely brakes.
So when you first start an antidepressant, you increase NA and 5-HT, and the brakes just slam on even harder, trying to bring the system back to where it was.
Exactly. The system fights back initially. But if you keep applying the drug consistently for 2 to 3 weeks, the system adapts. Those brakes become less sensitive, they desensitize. And once the brakes come off, then you get a significant, sustained net increase in the release and overall availability of NA and 5-HT.
And it is the sustained high level of monoamine transmission that promotes the structural changes you mentioned.
That's the modern synthesis, the chronic, sustained increase in monoamines enabled by that autoreceptor desensitization. That's what promotes BDNF production. BDNF then activates things called receptor tyrosines and kinases. These are surface proteins that regulate cell growth, and that enhances axonal and dendritic sprouting.
So it leads to new synaptic connections,
Yeah.
real physical neural plasticity.
That's it. The clinical delay is explained by the time the brain needs for this biological rewiring to physically take place.
So the NA5-HT increase is the fuel, but BDNF is really the structural engineer. That reframes the entire discussion, moving us away from thinking of this as a simple deficiency and toward understanding it as a process of induced structural repair. Okay, so with the chemical goals established, boost monoamines, promote BDNF, let's look at the first pharmaceutical methods used to achieve this. We have to start with the monoamine oxidase inhibitors, or MAOIs. These are historical pillars, but they represent a very, very specific risk profile.
MAOIs are fascinating because their antidepressant effect was found purely by accident. It was 1953, and compounds like iproniazid were being tested for tuberculosis, and the patients were just surprisingly buoyant.
Unexpected side effect.
A very unexpected side effect. The mechanism they exploit is fundamental. They target monoamine oxidase, or MAO, which is the enzyme responsible for breaking down biogenic amines like NA, DA, and 5-HT. So if you inhibit MAO, you increase the storage and eventual release of these amines.
Now, we need to clarify the two types of MAO because this distinction is absolutely vital to understanding the safety concerns.
It is. We have two key isoforms, MAOA and MAOB. Now, MAOA is the primary target for antidepressant action because it's predominant in the brain and periphery, and it's responsible for metabolizing serotonin, noradrenaline, and dopamine. Inhibiting MAOA gives you that mood lift.
And MAOB?
MAOB is more common in glia and platelets, and while it metabolizes DA, its main practical concern for us here is its ability to metabolize dietary tyramine.
And the original MAOIs were non-selective and irreversible, meaning they just shut down both MAOA and MAOB completely, permanently, until the body could synthesize new enzyme.
Right, and that non-selective inhibition leads directly to the single most famous and frankly terrifying drug interaction in psychiatry, the danger of tyramine and the cheese reaction.
This is a crucial story for understanding pharmacological risk.
It is. To survive digestion, tyramine, which is a precursor to noradrenaline, and it's found everywhere in fermented foods like aged cheeses, cured meats, beer, yeast extracts, red wine.
All the good stuff.
All the good stuff. Has to be broken down by MAO located in the wall of the gut and the liver.
But if the MAO in your gut is completely inhibited by a non-selective MAOI, that protective barrier is just gone.
It's gone. The tyramine survives, it enters the systemic circulation in huge unchecked quantities, and it acts as a massive indirect sympathomimetic agent. It causes a sudden explosive release of stored noradrenaline from nerve endings throughout the entire body.
And the clinical result of that is
A severe, life-threatening hypertensive crisis. We are talking about blood pressure spiking dangerously high, leading to an explosive headache, profound sweating, potential stiffness of the neck, cardiac arrhythmias, and a genuine risk of intracranial hemorrhage and stroke.
Wow.
This is why those first-generation MAOIs required extraordinarily strict, lifelong dietary restrictions, which made them impractical and often a very last resort.
So how did researchers manage to keep the efficacy of MAO inhibition while, getting around this existential dietary threat?
Through selectivity and reversibility, they developed RIMAs, reversible inhibitors of MAOA. The best example of this is meclobamide. It is selective for MAOA, meaning it primarily boosts 5-HT and NA, and it is reversible.
And why is reversibility the key safety innovation here?
The reversibility means that the inhibitor meclobamide is just weakly bound to the enzyme. So if a person accidentally consumes a meal that's high in tyramine, the flood of tyramine can actually compete with and displace meclobamide from the MAOA enzyme in the gut.
So it knocks it off.
It knocks it off, freeing up just enough MAOA to metabolize the tyramine before it can cause a catastrophic release of noradrenaline. It still requires caution, of course, but the risk of a fatal hypertensive crisis is significantly reduced, making those dietary restrictions much less draconian.
That's a brilliant pharmacological solution, turning a deadly irreversible block into a competitive reversible process. Now, beyond the risk management, RIMAs still carry typical side effects like nausea, dizziness, restlessness. And as we noted, meclobamide has found a specific clinical niche, often being useful in treating social phobia.
Okay, so if the MAOIs were fraught with dietary danger, we have to talk about the second major pioneer, the tricyclic antidepressants, or TCAs. These presented an entirely different kind of risk. These were the first true commercially viable antidepressants, introduced around 1958 with imipramine. TCAs dominated the market for decades, and let's be clear, they are incredibly effective. Their structural classification is based on their side chain, which influences their affinity for the two monoamine systems. We classify them into tertiary amines, which inhibit both NA and 5-HT uptake, like imipramine and amitriptyline, and then the secondary amines, which are predominantly noradrenaline reuptake inhibitors, like desipramine and nortriptyline.
Mechanistically, they achieve the goal. They inhibit the noradrenaline transporter, NET, and the serotonin transporter, SERT. They boost both systems, and theoretically, they promote that BDNF response, yet these highly potent drugs are now relegated to second or even third-line treatment. Why?
Because they are the ultimate example of what we call the dirty drug concept. Think of the TCA molecule as an old-fashioned circuit breaker. It successfully flips the main switch, the NET and SERT inhibition, but in the process, it short-circuits 3 or 4 completely unrelated systems.
It's just not precise.
Not at all. They indiscriminately block muscarinic or cholinergic receptors, histaminic H1 receptors, and alpha-adrenergic receptors.
Okay, let's elaborate on what that indiscriminate blocking means for the patient. Starting with the autonomic nervous system, the ANS effects.
The ANS effects are the direct result of their potent anticholinergic action blocking those muscarinic receptors. This leads to that classic set of side effects that everyone hates: dry mouth, blurred near vision, difficulty passing, urinary hesitancy, and constipation. For men, particularly elderly men with an enlarged prostate, that urinary hesitancy can be severe, sometimes leading to acute retention.
And these effects are, annoying, but the cardiovascular risks are where the danger becomes lethal. Tell us more about the CVS effects, the cardiotoxicity.
This is the critical safety factor. The cardiotoxicity stems from 2 main issues. First, they cause tachycardia or rapid heart rate, both due to their anticholinergic effects and their NA boosting properties. But second, and far more seriously, they possess what we call a quinidine-like myocardial depressant effect.
Okay, what does quinidine-like mean in practice for the heart?
Quinidine is an antiarrhythmic drug that works by blocking fast sodium channels in the heart tissue. TCAs inadvertently do the same thing. They stabilize the cardiac membrane, which slows electrical conduction through the ventricles. At therapeutic doses, this just causes T-wave suppression on an ECG. But in an overdose, it leads directly to severe life-threatening ventricular arrhythmias, including ventricular fibrillation.
Which makes them deadly in a potential suicide attempt. I mean, if you prescribe a drug to someone with suicidal ideation and that drug is lethal in a small overdose, that is just an unacceptable risk profile in modern medicine.
Absolutely. And on top of that, the alpha-adrenergic blockade causes significant postural hypotension, a sudden drop in blood pressure when you stand up, which increases the risk of fainting and serious falls, a huge problem for geriatric patients.
And the CNS effects?
sedation, confusion, and a dose-dependent risk of precipitating seizures. Clomipramine, which is highly effective for OCD, is particularly noted for its potential to lower that seizure threshold.
We also have to mention their pharmacokinetics. TCAs have long, variable half-lives, often up to 20 hours, so once or twice daily dosing is enough. But they have a terrifyingly narrow therapeutic plasma concentration range, typically 50 to 200 nanograms per milliliter.
That narrow window means slight variations in metabolism or dosing can push a patient from efficacy right into toxicity. Doses truly must be individualized and often monitored with blood tests.
So when we summarize, the acute poisoning dangers, lethality, and overdose is the single greatest reason TCAs fell out of favor.
It is the ultimate trade-off. While they are very effective, an overdose leads to excitement, delirium, convulsions, coma, and those fatal ventricular arrhythmias. Emergency medical teams have to use drugs like lidocaine to stabilize the heart and diazepam to control the convulsions.
Yeah.
The development of safer alternatives was not just an improvement, it was really a societal imperative.
And that imperative drove the pharmaceutical industry toward what we now call the second and third wave, beginning with the selective serotonin reuptake inhibitors, or SSRIs. This was truly the safety revolution that we needed.
The SSRIs immediately became the first-line treatment for depression and anxiety, and they still are, globally. The reason is simple. They maintain the efficacy of the TCAs, that serotonin boost, but they completely eliminated the cardiovascular and anticholinergic receptor blockade. They have a massive advantage in safety margin and are far, far less likely to cause fatality and overdose.
And the key to their safety, as the name implies, is their mechanism. They are highly selective inhibitors of SERT, the serotonin transporter. They focus like a laser on the one system they need to manipulate.
Right. They boost synaptic 5-HT without significantly interacting with the adrenergic, histaminergic, or cholinergic receptors that caused all the misery and danger of the TCAs. This specificity means a much cleaner side effect profile, which leads to higher patient tolerability, even if the side effects they do cause are often annoying enough to cause people to stop taking them.
Let's detail those common side effects, focusing on the ones that impact adherence. We mentioned the GI issues.
Oh, the GI issues, nausea, diarrhea, dyspepsia, are incredibly common, particularly early in treatment. And this is because 5-HT isn't just a brain chemical. It's a major signaling molecule in the gut, in the enteric nervous system. So boosting 5-HT globally stimulates 5-HT receptors in the digestive tract, leading to significant stomach upset.
And the other major adherence killer, sexual dysfunction.
This is perhaps the most significant long-term side effect. Patients commonly report delayed ejaculation or inhibited orgasm, sometimes in up to 50% of cases. It's often dose-related, but it can be profoundly distressing.
This is why drug selection sometimes targets atypical antidepressants if a patient has a history of these side effects.
Exactly. And in a strange twist of pharmacology, duloxetine, an SSRI, was specifically marketed for premature ejaculation. It shows how a side effect can become a therapeutic target when you use it intermittently.
Other common side effects include insomnia, agitation, general restlessness, but they are so much cleaner overall than the TCAs. We do, however, have to discuss the acute danger they still carry: serotonin syndrome risk.
Yes. Serotonin syndrome is the acute manifestation of having way too much serotonin activity in the CNS and the periphery. It is life-threatening and usually results from combining an SSRI with another serotonergic drug like an MAOI, another TCA, or even a triptan, which is used for migraines.
So what should you, the listener, look out for in terms of symptoms?
It presents as a triad of issues: cognitive changes, so confusion, disorientation; autonomic dysfunction, like hyperthermia, severe sweating, tachycardia; and neuromuscular excitability tremors, hyperreflexia, muscle rigidity, often in the lower limbs.
So if a patient is on a high dose or has combined medications and presents with a high fever and muscle stiffness, that's an emergency.
That is an immediate medical emergency. It just underscores the critical need for a detailed patient history regarding all medications.
Let's move to the individual drugs, because the source material highlights that despite being in the same class, they each have distinct pharmacokinetic and clinical properties. We have to start with the original, fluoxetine Prozac.
Fluoxetine has a unique profile. It's defined by its extraordinarily long half-life. The parent drug's half-life is 2 to 4 days, and its active metabolite, norfluoxetine, lasts 7 to 10 days. This means it takes weeks to wash out of the system.
Okay, so what are the clinical pros and cons of such a long half-life?
The major advantage is that if a patient occasionally misses a dose, the plasma concentration doesn't drop significantly. It offers a kind of built-in adherence safety net. It's also approved for use in children for OCD and depression. The major drawback, however, is that if a patient experiences severe side effects, they're kind of stuck with those effects for a long time because the drug clearance is so slow.
Next up, sertraline.
Sertraline is extremely popular today, partly because of its relatively balanced profile and its shorter half-life, around 26 hours. It's highlighted specifically for its perceived safety in patients who have had a myocardial infarction and its broad efficacy across anxiety disorders, including panic disorder and PTSD. It's a robust, all-around option.
And paroxetine.
Paroxetine, or Paxil, is known for being potent, but it has a slightly higher affinity for the muscarinic receptor than most other SSRIs, meaning it can sometimes exhibit mild anticholinergic effects like dry mouth, but nowhere near the TCAs.
Right.
It's also known for causing more sexual dysfunction and, crucially, a significant discontinuation syndrome upon withdrawal.
What happens during withdrawal? What does that feel like?
Because it's cleared relatively quickly, patients who stop paroxetine abruptly can experience flu-like symptoms, dizziness, electric shock sensations, sometimes called brain zaps, and profound anxiety. It really highlights that abrupt stoppage of any psychotropic drug is usually ill-advised, but is particularly problematic with paroxetine.
Finally, we have citalopram and escitalopram.
Right. Citalopram is widely used, but the source flags a significant cardiac concern.
It does. Citalopram carries a dose-dependent risk of QT interval prolongation on the ECG. This means it slightly delays the heart's electrical recovery time, which, at high doses, can potentially lead to a dangerous type of arrhythmia called torsades de pointes. Clinicians have to monitor dosage carefully, especially in patients with pre-existing cardiac issues.
And that leads us to escitalopram.
Yeah.
This requires us to briefly touch on chirality, the chemical handedness of molecules.
Oh, this is fascinating.
It is. Citalopram is a racemic mixture, meaning it contains two mirror image molecules, or enantiomers, the R and the S forms. Escitalopram is just the purified S plus enantiomer. The R form is relatively inactive and might even counteract the therapeutic effects.
So they just isolated the one that works.
They isolated the active S form. And by doing that, escitalopram is effective at half the dose of citalopram. It's generally associated with milder side effects, and it's now one of the most widely prescribed SSRIs. This separation represents a real pharmaceutical refinement, maximizing the therapeutic index and minimizing that side effect burden.
So we saw the incredible safety benefits of the SSRIs. But some depression responds better to a dual-action agent, boosting both serotonin and noradrenaline, much like the TCAs did, but without all the toxic off-target effects. And this brings us to the SNRIs, the third wave.
The SNRIs, drugs like venlafaxine, disvenlafaxine, and duloxetine, are really the best of both worlds. They are dual-action reuptake inhibitors, targeting both NET and SERT, but their molecular structure ensures they completely lack the anticholinergic, antihistaminic, and anti-alpha-adrenergic properties that plague the tricyclics.
So what clinical advantage do they offer over a standard SSRI?
For some patient populations, they can exhibit a faster onset of antidepressant effect. They're often used when SSRIs have failed. They're also highly effective for generalized anxiety disorder, social anxiety, and they've shown utility in managing mood swings in menopausal women. Venlafaxine specifically often provides a broader spectrum of efficacy than pure SSRIs for severe depression.
And the source material specifically highlights duloxetine as having a critical specialized niche that makes it a first-line agent for a surprising range of conditions beyond mood.
Yes, duloxetine's specialization lies in pain. Both the serotonin and noradrenaline systems descend from the brainstem down to the spinal cord, and they modulate pain perception. Duloxetine leverages this. It has profound efficacy in treating chronic painful conditions, which makes it a first-line drug for ailments that often coincide with depression, like diabetic neuropathy, fibromyalgia, and chronic low back pain.
So if a patient presents with major depression and chronic pain, an SNRI like duloxetine is a synergistic choice. It's treating two conditions with one drug.
Exactly. It recognizes the biological overlap between mood and nociception, which is pain processing. It's a perfect example of precision prescribing, selecting a drug whose side effect profile is actually a therapeutic benefit for the comorbid condition.
Okay, so we've established this generational evolution from dangerous and dirty to safe and selective to safe and dual action. Now we enter the realm of the specialists, the atypical antidepressants. These drugs are used to solve specific problems that the SSRIs or SNRIs can't manage, often related to unique side effects like insomnia or sexual dysfunction.
The atypicals prove that the BDNF boosting neuroplasticity goal can be achieved through really diverse molecular pathways, not just simple NET or SERT blockade. They are toolkit drugs. Each one has a very specific purpose.
Let's start with trazodone. What is its unique mechanism?
Trazodone is complex. It acts as a weak 5-HT uptake inhibitor, but its major mechanism is acting as a 5-HT2A receptor antagonist and an alpha adrenergic blocker. Clinically, however, its most notable feature is its strong H1 antihistaminic activity, which means it is profoundly sedating.
So its modern use is often disconnected from its primary label as an antidepressant.
Absolutely. While it's low in cardiotoxicity and was once used for depression, today, trazodone is most frequently prescribed in very low doses, sub-antidepressant doses, purely to treat insomnia. The sedation is the feature, not the bug. Its role in treating severe depression has largely been overtaken by the SSRIs and SNRIs.
Next is bupropion, which is completely distinct because it avoids the serotonin system almost entirely.
Bupropion is totally unique in this group. It inhibits the reuptake of both dopamine, DA, and noradrenaline, NA. Structurally, it actually bears a chemical similarity to amphetamine, which contributes to its generally more activating and stimulating profile.
And what are the two major clinical advantages bupropion offers?
First, it is associated with minimal to no sexual side effects, which makes it a critical choice for patients who cannot tolerate SSRI-induced sexual dysfunction. And second, it is a primary agent for smoking cessation. Marketed as Zyban, it helps reduce nicotine cravings and withdrawal symptoms and performs comparably to nicotine replacement therapies in clinical trials.
But bupropion carries a very specific and dangerous contraindication.
It does. Bupropion is contraindicated in patients with a history of seizures or any risk factors for seizures, like anorexia nervosa or bulimia. It significantly lowers the seizure threshold in a dose-dependent manner. This is the major limiting factor in its use, and physicians have to screen rigorously for seizure history before prescribing.
And finally, let's analyze mirtazapine.
Mirtazapine is classified as a noradrenergic and specific serotonergic antidepressant, or NASA. It works through a really unusual pathway. Instead of blocking a reuptake transporter, it acts on receptors directly. It blocks the presynaptic alpha-2 autoreceptors. Remember those brakes we discussed earlier?
So mirtazapine chemically removes the brakes, which increases NA release.
Precisely. And it also blocks specific serotonin receptors, 5-HT2 and 5-HT3, which are linked to anxiety and nausea, respectively. Like trazodone, mirtazapine is highly sedating due to potent H1 receptor blockade.
That sedation means it's also often given at night, but it has another famous side effect that can be beneficial in certain contexts.
Right. Mirtazapine is known to reliably increase appetite and promote weight gain. Now, if a depressed patient is experiencing significant anorexia or weight loss, mirtazapine can be a huge therapeutic advantage. However, for most patients, weight gain is a serious compliance issue, and that has to be managed. It just highlights that tailored approach. Mirtazapine is the right tool if you need sedation and weight gain.
This all shows that we are really dealing with multi-purpose tools. The source material emphasizes how widely these drugs are used outside of primary depression treatment, which just underlines the vast influence of monoimmune systems across the entire central nervous system.
Absolutely. The clinical use of these agents for pain, for sleep, for behavioral disorders, it proves that they are regulators of systemic nervous function, not just mood pills.
Let's look at obsessive-compulsive disorder, or OCD.
For OCD, the treatment requires intense serotonergic activity. SSRIs are the first line. Fluvoxamine and fluoxetine are popular choices. But the source notes that the older TCA, clomipramine, is still highly effective, showing significant improvement in over 50% of patients.
But there's a specific dosing requirement for OCD, isn't there? It's different from depression.
Yes, treatment for OCD demands higher doses of SSRIs or clomipramine and a much longer duration of treatment, often 2 to 3 months before you see the maximum therapeutic benefit compared to the 2 to 3 weeks you might need for depression. The bar for reducing intrusive thoughts and compulsions is just pharmacologically higher.
And the major overlap. Anxiety disorders. We've touched on this, but it bears repeating that SSRIs and SNRIs are the default long-term management strategy for almost all anxiety.
They are the absolute mainstay for generalized anxiety disorder, GAD, phobias, panic disorder, and post-traumatic stress disorder, PTSD. Sertraline, in particular, is noted for its utility in PTSD and anxiety. They offer the long-term non-addictive stability that's needed to manage pervasive anxiety.
And speaking of pervasive, let's revisit chronic pain and fibromyalgia. We noted duloxetine's role, but are the TCAs still useful here?
Oh, absolutely. The analgesic effect of TCAs, especially amitriptyline and nortriptyline, is independent of their antidepressant effect, although the mechanism isn't perfectly understood. They are invaluable for neuropathic pain diabetic neuropathy, post-herpetic neuralgia, reducing pain intensity in about half of patients. In fact, for chronic neuropathic pain, amitriptyline, duloxetine, and gabapentin are often considered the gold standard first-line drugs.
And finally, those two critical specialized uses we highlighted, premature ejaculation and smoking cessation.
For premature ejaculation, the strategy is just leveraging that SSRI side effect of delayed orgasm. Duloxetine is formulated specifically as an on-demand, fast-acting pill you take an hour before intercourse. And for smoking cessation, bupropion is the standout. The sustained-release formulation provides therapeutic outcomes comparable to nicotine replacement therapy, helping patients navigate that acute withdrawal phase with less discomfort and craving.
And a quick mention of ADHD in children.
Right. While stimulants dominate the field, in cases where stimulants are contraindicated or ineffective, TCAs like imipramine and nortriptyline and the selective noradrenaline reuptake inhibitor atomoxetine are used. They boost NA to improve attention and focus, offering an alternative pathway for managing hyperactivity.
We're going to shift our focus now from chronic mood regulation to acute emotional crisis management. We're discussing anti-anxiety drugs or anxiolytics. How do we even define anxiety in a therapeutic context?
Well, anxiety is a necessary human emotion. It's characterized by tension, fear, or apprehension. But when it becomes disproportionate to the situation, or if the accompanying somatic symptoms, the palpitations, breathlessness, profuse sweating, muscle tension become debilitating, that's when it requires treatment. Anxiolytics are CNS depressants designed to reduce that pathological anxiety without causing excessive non-functional sedation.
And for decades, the absolute gold standard for rapid relief has been the benzodiazepines, or BZDs.
BZDs are the established drugs for treating acute anxiety for one simple reason. They act fast, within minutes to hours. That speed is their singular advantage in a crisis.
So let's detail their mechanism. What exactly is a BZD doing at the molecular level?
It's all about the primary inhibitory neurotransmitter in the brain, GABA, or gamma-aminobutyric acid. You can think of GABA as the universal stop signal or the primary braking system in the CNS. BZDs don't activate the system themselves. Rather, they are what we call positive allosteric modulators. They bind to a specific site on the GABA receptor complex, and they facilitate the inhibitory action of GABA.
So they make the brakes work much more efficiently. They don't press the brake pedal, but they sort of oil the system. So when the body naturally applies the brakes with GABA release, the effect is amplified.
That is a perfect analogy. And this amplified inhibition occurs selectively in the limbic system, the emotional center of the brain, effectively suppressing fear, apprehension, and even aggressive instincts.
But the speed and this potency, they come with a severe therapeutic trade-off. This is the key distinction the listener has to internalize. BZDs are terrible for long-term use.
That is the crucial point. Their long-term use is associated with three major compounding drawbacks: tolerance, physical dependence, and withdrawal. Tolerance means the patient needs higher doses to achieve the same effect. Dependence means the body physically requires the drug to function normally. And withdrawal upon abrupt cessation can be severe, involving rebound anxiety, insomnia, and potentially life-threatening seizures.
And they also carry risks related to acute impairment, right?
Yes, they cause dose-dependent sedation, cognitive impairment, and profound psychomotor slowing. This translates directly to an increased risk of accidents, and specifically an increased risk of falls, which is especially problematic in the elderly population. And due to dependence, they must always be withdrawn gradually after prolonged use, often over weeks or even months.
Let's look at the variety of BZDs, as they differ so dramatically in half-life and potency. We start with the historical foundation, chlordiazepoxide.
Chlordiazepoxide was the very first BZD, a long-acting compound with a half-life ranging from 15 to 40 hours. It's effective for chronic, persistent anxiety, but its long action makes it particularly useful for managing the severe withdrawal symptoms associated with alcohol dependence.
Then there's the classic BZD, diazepam.
Diazepam is rapidly absorbed and also has a prolonged action profile. Its rapid onset means it's often used for acute panic or muscle spasm, providing a quickly felt mild sedative effect that lasts for a while.
And moving to the more high-potency options, starting with lorazepam.
Lorazepam is highly lipid-soluble, meaning it crosses the blood-brain barrier very quickly. It's often used for short-term anxiety and tension, but its critical role is in emergency medicine. Because it's available for intravenous injection, it is the standard drug used for aborting acute life-threatening seizures, a condition known as status epilepticus.
And alprazolam.
Alprazolam, which most people know as Xanax, is a high-potency BZD that is extremely effective, specifically in treating panic attacks and panic disorder. However, Its rapid onset and high potency often lead to a greater risk of dependence and misuse compared to the lower potency, longer-acting agents.
And finally, clonazepam.
Clonazepam is another high-potency agent, primarily valued not just for anxiety, but for its strong anticonvulsant properties, which makes it useful in neurology as well as psychiatry.
So given the dependence baggage of the BZDs, we obviously can't use them for long-term maintenance, and that's where we turn to dedicated long-term anti-anxiety agents, starting with buspirone.
Buspirone is a fascinating drug because it offers relief without any of the BZD drawbacks. It's another anti-anxiety drug with a completely distinct mechanism. It acts as a partial agonist at the 5-HT1A receptor, modulating the serotonin system differently from the SSRIs.
So what are the two massive advantages buspirone offers?
First, it does not produce the same level of sedation as BZDs. Patients can take it without feeling cognitively impaired. Second, and most importantly for chronic management, it does not induce tolerance, physical dependence, or withdrawal symptoms upon cessation. This makes it an ideal option for long-term management of generalized anxiety disorder, or GAD.
Okay, so if it's so much safer, why isn't it used for every anxiety attack?
The limitation is its delayed therapeutic effect. Buspirone takes 2 to 3 weeks, sometimes longer, to reach its full anxiolytic potential. It follows the exact same delayed time course we discussed with the antidepressants, likely requiring the same time-dependent neuroplastic changes. So if someone is having an acute panic attack, buspirone is useless. It is strictly a maintenance drug.
Another class of drugs sometimes used for anxiety are the beta blockers, like propranolol. How do they fit into the picture?
Beta blockers are used to treat the somatic symptoms of anxiety. When fear floods your system, adrenaline causes your heart to pound, your hands to shake, you start sweating profusely. Beta blockers interfere with the action of adrenaline and noradrenaline on peripheral beta receptors.
So they cut the physical feedback loop. They stop the body from having the physical symptoms of fear.
Exactly. They are highly effective for situational anxiety stage fright, performance anxiety, public speaking, a job interview. If your primary symptom is a racing heart before a big presentation, a beta blocker can silence that physical response. Crucially, though, they do not treat the core cognitive component, the worry or apprehension itself. So their role in pervasive GAD is very limited.
And this leads us to the final treatment strategy synthesis for anxiety, which really mirrors the shift we saw in depression treatment.
It does. The modern standard of care makes a very sharp distinction. Benzodiazepines are restricted to short-term acute crisis management, say, for the first few weeks of therapy, or for occasional panic attacks. The long-term sustained maintenance therapy for GAD, OCD, and PTSD relies almost entirely on SSRIs and SNRIs, and for specific GAD cases, buspirone. These agents, while they're slow to start, offer superior safety, a lack of dependence risk, and they promote the long-term structural stability needed for sustained recovery.
It's a move away from that quick chemical knockout, which the BZDs provide, toward the slow, intentional building of new neural structure through the antidepressants. #tag outro. This deep dive has really shown us that the story of treating mood and anxiety is fundamentally one of trade-offs between potency and risk in that first generation, and then between speed of action and long-term safety in the chronic management of anxiety.
To summarize, we've traced the arc from the MAOIs and TCAs, which were effective but carried that unacceptable risk of hypertensive crisis and cardiotoxicity, to the safer, selective second and third ways, the SSRIs and SNRIs. These revolutionized treatment by retaining the monoamine boosting, but, ditching the dirty receptor blockade.
We also defined the specialists. The atypicals, like bupropion for minimal sexual side effects and smoking cessation, and mirtazapine for its unique ability to induce sleep and promote weight gain. And we established that critical line in anxiety treatment, separating the fast, addictive benzodiazepines, which are for crisis, from the slow, non-dependent, long-term options like SSRIs, SNRIs, and buspirone.
The most profound learning point, I think, remains the neurotrophic hypothesis. We now understand that the lag time in clinical response is the body adapting and repairing itself, using the drug's initial action as the signal. The prolonged effective treatment requires promoting brain-derived neurotrophic factor, BDNF, and encouraging neuroplasticity.
And the knowledge that the effectiveness of these medications relies on physically encouraging the brain to remodel and strengthen its synaptic connections over weeks and months. It raises an important question for you, the listener, to consider. If the effective long-term treatment relies on encouraging the brain to physically rewire itself, does this fundamentally change how you view the line between a psychiatric illness, which we often think of as purely functional, and a neurological change, which is structural?
Yeah. Thinking about depression or chronic anxiety, not just as a chemical dip, but as a condition that involves potentially reversible atrophy or structural deficiency, it gives us a very hopeful new framework. It suggests that therapeutic intervention is literally about encouraging the brain to build resilience at a physical level.
Thank you for joining us on this deep dive into the pharmacology and the structural science of decoding antidepressant and anti-anxiety drugs. We'll see you next time.